right, good afternoon. Hello, everyone. Welcome. Thank you for joining us today. I'm very excited to have you here today with our guests, Mandy, Haley, and Drs. Thatcher and Figurado. As we settle into this space, I'll ask that everyone keeps their video off and microphone muted. So this allows everyone to see the speakers in a spotlight, and you should be able to adjust your own view to hide non-participants if needed. Closed captions are enabled for participants to turn on. And at the end of the webinar presentation, there will be 10 minutes for a presentation. Sorry, there'll be 10 minutes for Q&A after the presentation. So if you have any questions, please place them in the chat. So my name is Joelle Schaefer. I'm the Community Engagement Specialist with the Division of Social Accountability. I'm joining you today from the College of Medicine's main campus in Saskatoon, Treaty 6 territory in the homeland of the Métis. I acknowledge the land that I am on today and the relations of Indigenous people to this land since time immemorial. The University of Saskatchewan stretches across our province to Treaty Lands 2, 4, 5, 6, 7, 8, and 10. And all people who call Saskatchewan home are Treaty people. In the spirit of reconciliation and commitment to justice in my daily work, I work and put effort into building lasting and meaningful relationships, to hearing diverse experiences and perspectives, and inviting lived experience to the forefront of these conversations, addressing health inequities for all who experience oppression, and decolonizing my own way of thinking. The Division of Social Accountability, for anyone who's unfamiliar, is a division of the College of Medicine dedicated to health equity, anti-racist education, authentic community partnerships, and advocacy to address the priority health concerns of Saskatchewan communities. So we engage with and learn from our communities to support relevant, meaningful, and impactful health education, research, service, and advocacy. The Health Equity webinar series focuses on the priority health concerns of Saskatchewan communities with a goal of supporting students, faculty, and staff in their learning. Our webinars are open for all to attend, so I encourage you to share invites with friends and colleagues, and our webinars, including today's, are also recorded. So if you've missed a topic in the past, you can find it on our YouTube channel. So I'll place two links quickly here into the chat. And one is a link to sign up for the DSA mailing list, which is a great way to find out about our future learning opportunities. And the other is a link to our YouTube channel. So this webinar was planned in part as a lead up to December 3rd, International Day of Persons with Disabilities. And disability and ableism were identified by Saskatchewan communities as a priority health concern. So I am very excited to introduce our guests today, who will speak to the importance of and challenges around inclusive healthcare in Saskatchewan, as well as the strengths of the COR approach. So Creative Options Regina, COR, is a for-impact charitable organization that develops personalized support services for people experiencing disability. It is rooted in the philosophy of gentle teaching, and COR strives to strengthen the fabric of companionship and community for all those served. I had the very wonderful opportunity to visit COR with some of my colleagues last week, and I'm excited for our learning today to be enriched with our COR guests. So I'd like to introduce Haley Zora, a registered dietitian with the health team at COR, Mandy Boersch, the director of health at COR, Dr. Alicia Thatcher, a family physician who specializes in adults with developmental disabilities, as well as an assistant professor in the departments of pediatrics and family medicine, and Dr. Priya Figurado, an assistant professor at the College of Medicine in the Division of Neurology and a clinician at the Regina Neurosciences Clinic. Welcome.
Perfect. Thank you, Joelle. My video and audio are logged in separately, so apologies if that's confusing. But I'm Alicia Thatcher, family physician with extra training in care of adults with IDD, or intellectual and developmental disabilities. And today with our guest speakers, we will be talking about our approach with COR for providing inclusive healthcare to adults with IDD. And I'll just let everyone kind of unmute and say hi before moving on. The next slide just shows the speakers.
Hi, I'm Dr. Figurado. I'm the neurologist. I'll talk a little bit about the challenges with the neurology side.
Hi, I'm Haley Zora. I'm the RD at COR.
And I'm Mandy. I am the Director of Health at COR and a registered psychiatric nurse.
Perfect, thank you. So the next slide is just the overview. What we'll talk about today is the problems that we're trying to address, what the need is, an introduction to COR, the clinical team, and our approach. A specific case example that demonstrates some of those aspects that are unique, the facilitators that we think are helping us to be successful in our approach, and then some future directions. The next slide goes into kind of what the problem is. There are many other statistics and a lot of literature across the world that demonstrates similar findings, but this was specifically done in Ontario, looking at a very large amount of data between 2010 and 2016 that found consistently higher rates of poor health outcomes for adults with developmental disabilities compared to those without, including nearly 2 times higher 30-day repeat emergency department visits, more than 3 times higher 30-day repeat hospitalizations, the likelihood of having to remain in hospital despite being recovered enough for discharge, which is called ALC or alternate level of care, about 6.5 times higher, really reflecting the gaps in the community to support people outside of the hospital. Long-term care, 17.5 times higher likelihood of living in a long-term care facility. And then the likelihood of dying before the age of 75 years, premature mortality is nearly 4 times higher. And in many cases, the causes are preventable. So the next slide shows a graph with life expectancy, and it just shows that it has drastically increased for people with IDD over the last several decades. And that's thanks to advances in pediatric medicine, especially. However, the research, literature, guidelines have really not kept up. So as a result, we're seeing quite significant disparities in health outcomes. And then some of the barriers to healthcare for people with disabilities. And I kind of broke it down into the 4 different levels. Looking at the health environment, there's an absence of disability standards and provider training, insufficient data, lack of inclusive health promotion programs. Within the healthcare system, there are scheduling constraints that can be very limiting, so short appointment times, needing more time to process new information or to express oneself. Payment and reimbursement issues. So a typical physician payment model really doesn't compensate physicians for the number of issues addressed in a visit or the amount of time spent with a patient or level of complexity. And also in terms of just payment restrictions. So patients often can't afford the recommended treatment or therapy. So we often have to settle for substandard treatments or just go without altogether. And there's a lack of age-appropriate services and supports. And then within the clinical practice, accessibility is a big concern for both the office, the equipment, thinking about transportation, curbs, stairs, narrow doorways or hallways, small bathrooms, lack of elevators. The exam table itself is often not adjustable, or there's no mechanical lifts. That's very rare to actually find in a clinic. So often for wheelchair users who do not transfer independently, they often need to go to hospital for different outpatient exams like ultrasound, for example, that would otherwise easily be done in the community for other patients. And a physical exam might be completed while a patient is in their wheelchair as a result, so it's often not as thorough. Other things like safety mobilizing outdoors, especially in the winter or living in rural settings. This applies to imaging clinics, dental optometry, medical, fitness centers, all sorts of different places. Any sensory differences or sensory impairments can affect accessibility. There's often a lack of staff training, lots of different communication barriers, like exclusively relying on telephones to book or modify appointments, or wearing masks can affect the ability to lip read or see facial expressions or just build rapport in general. And then at the provider level, there's often a lack of disability training or just experience and comfort, poor attitudes. So we see unrecognized knowledge gaps, maybe rejected referrals with no clear explanation, ableist language and discharge summaries, and incomplete knowledge of care coordination. So on the next slide, we want to paint a picture of what many encounters when we see patients with IDD are actually like for a lot of healthcare providers. So in medical school, we learned that when we are in the process of arriving at a diagnosis for a patient, the process is really 70% approximately of what we gather is the history to get to that diagnosis. The history we obtain helps us to narrow down what we're looking for in the physical exam and interpret those findings. And then only about 10% of getting to that diagnosis is actually from results of different investigations, like blood work, imaging, biopsy, etc. So that's just a typical experience or expectation of a physician assessing a patient. Now, often in these cases, patients arrive at an emergency department, for example, without a support person or with someone that is supposed to provide support, but they have no healthcare background or they're new on the job, they only work part-time, they don't have the full story. So we might have a patient who doesn't use words to communicate or just maybe less capable of expressing themselves when they're unwell. They don't have a support person who can answer most of our questions. And then we do the physical exam, but it's without much history to actually guide us. The findings are without context to understand kind of what's different from baseline, or the timeline of when something started or how it changed is something we don't have. So we can try to order tests, but we don't necessarily know exactly what to order without the guidance of the history or physical. We don't necessarily know how to interpret it without knowing the person's baseline. And so having a familiar support person assist and having accurate objective documentation really makes all the difference. And nearly all agencies supporting people with IDD don't have nursing support or healthcare professionals directly embedded in the agency. I'll just pass it over to Priya to talk a little bit more about the neurological perspective before moving on to this other slide.
Thank you, Alicia. Yeah, so just specifically about neurological, trying to provide neurology care. Some of the challenges are with regards to epilepsy, which is the most common condition that I would encounter with this patient population. Identifying if a patient is even experiencing seizures can be quite challenging. Some seizures are more obvious. They look like seizures. Most people can identify that, but a lot of seizures are a lot more subtle. Sometimes they're just experiences internally, like a feeling, a sensation of impending doom, a deja vu, feeling like you're out of your body. And these can be experiences that are difficult for anybody to identify as a seizure, and even more challenging if you are having any limitations with the way that you communicate verbally. So these can be really difficult to identify. Sometimes a seizure you feel like something is happening, a sense that you're about to have a seizure, and then there's a behavioral arrest. And I often rely on patients to give me that information that they have lost time. But again, this can be challenging with different populations. The other challenge that I face is sometimes movements that look like seizures don't end up being seizures. And there's specific features, patterns that I look for and I ask for to help me to identify whether something is a seizure or not, so that I'm not over treating for seizures. And so this would be can be difficult if someone has stereotypies, or if there is even some movement disorders or tremor that can look like seizures in some cases. And often if sometimes we will just interpret something as a seizure and tell the physician this is a seizure, but a lot more detail is important and necessary for me to be able to identify that correctly. The other challenge is a condition called psychogenic non-epileptic seizures, which look very much like seizures, but sometimes there are clues and cues, context, contextual information that tells us it's more likely to be a psychogenic non-epileptic seizure rather than an epileptic seizure, and the two are treated completely differently. The other challenge is the medications that we often use to treat seizures can have a wide array of side effects, including behavioral changes, mood changes, changes in level of alertness and consciousness. balance difficulties, falls. And again, it's important to be able to identify what if the onset of these symptoms correlates with changes in the medications that we use for the seizure. And sometimes that information is really, really difficult to obtain. Even simple questions that I used to take for granted prior to working more with this patient population is when was the last seizure? It seems like a really simple question to answer, but sometimes that information is just not available because the patient themselves can't give that to me. And again, same with the staffing, if there's a high turnover or they don't have documentation, that even just something that seems as simple as when was the last seizure can be a question that I can spend months and months and months with a patient with repeated visits and still not have the answer to when was the last seizure. And then that's just the starting point. So that can be really challenging. Other questions that I need answered to be able to treat somebody well would be the frequency of the seizures. Are the seizures responding to the medications? Are there side effects from the medication? So this is all information that, again, you kind of take for granted sometimes. The other symptom other than epilepsy that I see often would be things like changes in gait, balance, falls. And that's pretty challenging too, because it can be multifactorial. It can be because somebody has numb feet with neuropathy. It could be ataxia. It could be because the patient feels like the world is suddenly moving. And again, it's something that can be easily recognizable and sometimes very difficult to recognize. And sometimes you can have all three. You can have something like a neuropathy, you can have myelopathy, you can have ataxic gait from cerebellar ataxia, all in the same patient. And things can progress and be masked by the other symptoms that are co-present. And it's, as a neurologist, because I can only see patients at certain intervals, things can change very rapidly during that interval. And if there aren't other care providers that are involved that know what the patient's baseline is like, that are recognizing that, even though someone is using a gait aid, there's a clear deterioration, a clear change, things can progress very rapidly without presentation. So those are some of the challenges that I become faced from a neurologic side.
Yeah, and then in terms of what we see when we're supporting a person in various healthcare settings, more or less they're often more stressful. This comes from just a history of really negative experiences for a lot of people with IDD, in terms of whether they come from an institution, or maybe they had long stays on psychiatry, or they've had a lot of health concerns that have come up, so they've had to go to the hospital in and out for their entire life. A lot of those experiences have been quite negative, and that comes from so many other things that, like the environment, much to which Dr. Thatcher spoke about before, but the sensory component, the accessibility, crowding can be very triggering, overstimulation, the short appointment times, and then long wait times. So sometimes when we have appointments, we have to be really creative in how we spend the time beforehand, because if we have to go into a waiting room and we're there for 2 hours, the chances of us being there for a lot of people are really slim. So we have to figure out a way to have someone there, but then maybe we're driving around and then we come back in when they call us. Or for those places that we do have relationships set up with, we're able to talk that through beforehand, and they know kind of what we need in order to make the appointment as positive as possible. There's always a discussion, especially when it's maybe a new practitioner, as soon as they see a diagnosis of any kind of disability, whether it's, say autism, for example, the discussion goes directly to behaviors, and have we done something to mitigate their behaviors? And typically in this population, that is talking about ABA, or applied behavior analysis. And that is what's been used for years, and it's more of a rewards and punishment system for, if you do good here and you have a good behavior, you're going to get this reward. And so a lot of times that would be used for appointments, and it doesn't always have a positive outcome. So behaviors gets used so often, and a lot of times we've experienced where, well, if you don't, we need to navigate this before we're going to do anything further, because they're unsafe to be here and you can't bring them here. This is how it's going to be. So a lot of the focus gets sidelined and is talked more so about what we're doing to make them behave better. And then once we get a relationship set up and things are going good, we see a lot of turnover in family medicine. So we spend a lot of time trying to find new physicians to build relationships with, but then taking to new intake appointments over and over again gets super stressful again for the person that we're supporting. And the chances of them wanting to come to the appointments gets less and less the more we have to do that. So it's really difficult to find places where we can go consistently where people aren't leaving after a certain period of time. And then I guess also navigating the systems. It's so complicated knowing where to go to access support, funding, equipment, medication coverage, financial support. These are all different areas in the disability sector that have to be navigated. And if there's not someone there to help assist that, it becomes very daunting. And then it's more like, I'm just not going to try. So we kind of are up against all areas when we're helping people navigate the medical system.
All right. So, sorry. As you can see, the problem really is things compounding together. So when we start to support a new person, we may or may not get a history of their time with other agencies or homes or living situations. And then oftentimes, if we do get that information, it's subjective, incomplete, or inaccurate. So as Mandy mentioned, this information also focuses heavily on behaviors, often pathologizing people to fit categories instead of focusing on the person as a unique individual. Also, as mentioned before, polypharmacy is quite common for people we support. So when they meet a new doctor, which we noted can already be a stressful experience, doctors are sometimes hesitant to make too many medication changes, and it's either because they don't know the person well enough, they don't have the capacity to follow so many medication changes at once, there's fear of adverse effects, or they don't know to ask if the person is doing well with their current medication. So if that person had been seen by someone consistently, they would know that person well and be able to make a more informed recommendation. Then we can triage between what medication is needed and then what can be titrated or trialed. So the main theme that we see in our work, however, and Mandy already mentioned this, is that you have to find ways to be creative in how you support someone with IDD. Knowing the person not only helps with connecting with healthcare professionals, as we've said, but it's also really critical for implementing any recommendations or medication changes, lifestyle changes, or any other outcomes from appointments. So like any other population, there's no one-size-fits-all solution to health and interventions, and we need to find something that suits the person who needs them. So sometimes that takes extra imagination and collaboration with the person you support and their team to come up with a more person-centered solution.
And then we had one of the people that we support, his name's Jason. He agreed to come in and share some of his lived experiences in the medical setting. He's been supported by COR now for close to 12 years or so. And he's in a lot of our videos that we do, but he speaks really well to some of the experiences. So you're going to see a couple of videos of him throughout this presentation.
I think that health is scary for me because I didn't know what health was about with me, and I didn't know what needles were. I didn't know what heart surgery is, because I didn't know what an operation is. And I keep asking my mother, okay, well, mother, like, what is a surgery room, or what is and she explained it, and I know where it was and what I had to go into, and then that was okay. Like even when they talked about my high blood pressure, and then I got really nervous about that because I had to take other meds for that. They were saying that that you might have a pre-diabetic, and they just said, well, if you do have diabetes, then you have to take a lot of needles. I had lots of doctors when I was maybe a kid. Students that want to be doctors, or how to be a surgeon, or how to be an eye doctor or dentist. My advice to you is to be kind. Students need to know there's nothing wrong with disability, and to support them and to make them feel relaxed and not feel more nervous. If somebody has a disability, then they have to know what the person's, when they communicate, because it's hard for a doctor to understand when the person has a hard time explaining what's wrong with their health, because you want to know who the person is who has a disability.
So the points that Jason brings up are really not uncommon. This just brings to light the question of what the need is. So care that is accessible, accommodating and flexible, equitable, effective and high quality, team-based and patient-centered.
So COR, like was introduced before, we are a organization that supports people ages, I think, 6 and up with IDD in the community. We are based on the foundations of gentle teaching, which is a concept that actually predates trauma-informed care and in fact influenced it. So it's a relational approach to caregiving that focuses on building companionship and interdependence rather than trying to change behavior. It's based on 4 pillars of teaching people to feel safe, loved, be loving, and engaged. The approach is to emphasize building trust and mutual connection through our words, our eyes, hands, and presence, and prioritizing a person's inherent worth over their actions. So like I said before, we don't use applied behavioral analysis. We don't use any kind of restraints in our homes. We have a no discharge policy. So once someone moves here, it is their home for life if they want it. It is volunteers, so if they want to move somewhere else, don't have to stay. We are the first organization in the province that supports youth into adulthood. So typically when a youth would be in care of an agency, when they aged out, they would have to move to a different one that supported people that were adults. Where we will have people that are youth and they come into their home and they can stay there and transition into adult service without having to move their home. So the other kind of difference between us is we don't ever have a vacancy or an empty bed, as some places would call it. We will be approached to support someone, and we build a team and a house and a plan around that person with the hopes that they have more input into where they're living and who they're living with. We try not to have the max people that we have living in a home is 4. So we have some homes that have 1 person living in them, some have 2, up to 4, depending on their needs and sort of what the best case scenario for them is. And we do have a lower staff turnover rate, which I think for the sector is approximately 35%. Over the past 15 years, we have ranged between 4 to 14%. So with that is because we apply gentle teaching across the agency. So there's a really strong component of taking care of the employees so they can be the best caregiver for those that we support. This is something that is taken very seriously in terms of wages, benefits, positive work culture. Our employees are found by word of mouth and often like referrals. We get lots of applications through this and have many agencies providing similar services that have vacant positions. And then we have a slower hiring process just to make sure that we're having the right people in the right houses. So it allows the individuals to have some control over who's coming into their homes and their lives, so they have a chance to meet in advance before the person's hired and can also give feedback. So it's trying to be as holistic as possible when providing a support team and the home.
I'm going to, sorry, we're in the same room. I'm going to introduce our clinical team. So it consists of a nursing team and then myself, the registered dietitian, and we're embedded within the agency. And then we have physician partners as well, like those who are presenting with us today. Nearly all agencies supporting people with IDD do not have in-house nursing or dietitian support, so this is unique to us. The fact that our team is embedded within the agency means that our approach aligns well with our organizational values that Mandy just mentioned, our gentle teaching. We're also all trained in gentle teaching, so we can better understand the context and the organizational support, the organizational approach to supporting people, which often clashes with the traditional medical approach. So our nursing team, we have an RPN, that's Mandy, our psychiatric nurse and director of health, 2 RNs, and then we've recently added an LPN. They all have experience and or extra training in IDD. For example, 3 of our nurses are Developmental Disability Nursing Association certified. That's that CDDN certification beside their names. And then we have 1 in training. So the role of our nurses, they check in with patients and families and supports to provide education and prompts to ensure progress through management plans and to identify clinically important trends, any issues that arise or barriers to address. And then they take that information and relay it back to medical team as indicated. They synthesize and relay that information regarding health pending or completed investigations and the outcomes of management plan between the patient, family, and caregivers and the medical team. They also develop relationships with support teams to provide ongoing training and education. They can answer questions that supports may not be comfortable asking doctors and can spend more time providing education and support. In addition, they provide crisis support in both medical and psychiatric settings. So for example, we recently had someone in failure to thrive, aspirating, and had immediate medical concerns. We supported them in getting to the hospital and then in the hospital. And then once they were transferred home, and then guiding their team through their medical complexities and training them in everything they needed to be trained in so that this person could remain in their home. For psychiatric crisis, we help rule out health, environment, and lived-in experiences, and then we can help access appropriate support with psychiatrists, all with the goal of avoiding hospitalization while keeping everybody safe. And then there's myself, the registered dietitian. My role, I have the dietary expertise to allow us to address severe medical concerns. Sometimes that prevents the need for new medications or doses to treat the issue, which is always really exciting. I'm also experienced in swallowing assessments, or if someone does have to go to the hospital for further swallowing assessments, I can implement and educate the teams on SLP recommendations. So common examples of things I do, I can work with people with diabetes or elevated blood pressure with existing polypharmacy. There's a high risk of drug-drug interactions, like I said, with all this polypharmacy, recurrent falls, osteoporosis or frailty. I also deal with a lot of unexplained change in weight and nutrient deficiencies identified through blood work or people who are at risk for nutrient deficiencies, particularly in cases when there's already high pill burden, sensory differences, or selective eating interfering with any kind of balanced nutritional intake. So for our main physician partners, we have a neurologist, a psychiatrist, and an IDD primary care consultant. So neurology, She sees many individuals supported by COR for their neurological specialty care, often due to epilepsy, like she mentioned. She may be consulted for ongoing epilepsy management or specifically due to increase in frequency, duration, or change in seizure type. Any new atypical spells with a history or suspicion of epilepsy, any kind of health decline coinciding with change in antiepileptics, or a concern for potential significant adverse effects related to those antiepileptics. There's a higher frequency of complex, rare, and refractory seizure disorders among people with IDD. It can also be more challenging to manage when patients are unable to communicate their symptoms or if caregivers are inconsistent or have minimal knowledge on seizures, as previously mentioned. Psychiatry, they see many individuals supported by COR for concurrent medical health concern or mental health concerns, may be consulted about adverse effects related to psychotropic medications, safety concerns related to mental health, behavior or negative changes to mood, anxiety, or activity level or functioning, with physical health and environmental factors ruled out or being addressed simultaneously. And they are easily accessed for crisis support to, again, avoid hospitalization for as long as we can. And then IDD primary care consultant, again, as previously mentioned, family medicine physician with extra training in care of adults with IDD. So all individuals supported by COR also have their own family physician. Many are able to access the care that they need from their own family physician. The IDD primary care consultant may get involved in co-follow patients due to an additional individual or situational complexity when facing some of the barriers discussed previously, such as long wait times, short appointment times, physician turnover, accessibility, or any of the other things that Alicia previously mentioned. So there's other important members of our team, and the extended team will look different for every patient depending on the extra care that they require. So one of the key team members that plays a very significant role is the supports. So supports are those who accompany, support, empower, and advocate for the individuals as they navigate the healthcare system. They facilitate communication between the individual and the healthcare provider as needed. They monitor and document anything of concern that we need to know about or in relation to particular interventions, and they communicate with the support team and the health team. So we are in contact a lot with the supports because they're who know the person best, and they give us a lot of information.
Our clinical approach is we find that a lot of people with IDD are on either one or multiple antipsychotic medications. So we do have a psychiatrist that works with us for everyone supported in the agency that requires psychiatric help. So it's a team-based approach. We see people every 3 months or more if needed, but we will go through and do rounds with the nurses, dietitian, the person supported, their team, the pharmacist, Dr. Thatcher when she's able, and then we usually have some students or residents that might be in training as well. We'll go through all of the previous 3 months of their health in terms of biopsychosocial factors, their overall health, if they do have anything to do with Dr. Figurado, we kind of combine everything into one, and then we'll identify who, if they're not already engaged with Dr. Thatcher, if things are getting more complex, then we'll ask for a referral to her for that person, and then we'll start the process with Dr. Thatcher at that time. We assess the safety and urgency to develop safety and crisis plans at these times if their health is changing, and team members help identify if other referrals are needed as well. So it's kind of a check-in every 3 months to make sure we're covering all our bases. And also just a time to gather more information from the team. As Haley said, they are kind of the key players that bring all the information that we need. We'll co-develop care plans as they come, and we'll make sure that any type of recommendations that are made, we will communicate them to the team after the fact, whether it's in a team meeting or through documentation. If family is involved, they'll come to the appointments as well. and we just have a discussion all together to make sure everyone's on the same page. For neurology, we have half clinic days where with Dr. Figurado, we'll join her at her office and go through everyone that she sees there. And the biggest things are that the person that we support is engaged in every step. So they have input before, during, and after those appointments. And sometimes if they can't make the appointment, and we'll talk to them beforehand when we do our mental health rounds, sometimes they're just not up to it, or things are going well and they don't feel that they need to be there, then we'll talk to them beforehand and let our psychiatrist know kind of how that went, or we might just phone them if that makes them feel more comfortable. Or we have people that want to come every time and they enjoy coming to the appointments. We'll make sure that the supports receive the training that they need after the fact if anything has changed in the care plan. And we employ the HELP framework, which Dr. Thatcher is going to speak to more in a little bit.
Perfect. So just paying attention to the time, I want to make sure there is still time for questions, and we do still have quite a bit left. So I'm going to kind of speed through the case a little bit instead of going in quite as much depth as I had initially intended. So this is Samuel, a 50-year-old male. The identifying information was changed a little bit, and consent was provided by the patient and family to share the case. So Samuel has an intellectual disability, unknown cause, and the exact severity or level of intellectual disability is unknown. He also has epilepsy, recurrent hyponatremia, which is low sodium, an unspecified mood disorder. He had shingles in the past and some environmental allergies. He's on a number of different medications. Most of them are anti-seizure medications, but there's also one for mood, melatonin for sleep, vitamin D3, and then as needed lorazepam for seizures. No known allergies to medications, developmental history, born full term, forceps delivery, no known complications with the pregnancy or the delivery, didn't need to be resuscitated or stay in the NICU after he was born. Did have a seizure at about age 1, and shortly after that was diagnosed with epilepsy. Milestones, the language skills were a little bit delayed. And then in kindergarten, he was diagnosed with an intellectual disability. Poor communication. He speaks English, fairly easy to understand, generally walks independently, but there's been some changes recently. And then he's been supported for about a decade. He lives in a house with one roommate and is pretty independent with eating, but needs some assistance with the other activities of daily living and full support for the instrumental activities of daily living, like shopping and managing finances, etc. And sorry, just had a pop up there. Okay, and then on the next slide there, so some concerns were brought up by both Samuel and the supports, including seizures have been more frequent. There's been some changes in mood as well as memory concerns, but also mobility. So declining mobility, recurrent falls, lots more fatigue, some right knee pain and coughing at meals. And then the next slide just shows some extra background information relevant to these concerns. So the seizures were previously about 3 to 4 per month at baseline, but it's been significantly more often. It's been more irritable, more forgetful. Did have a normal CT brain at a recent ER visit. 2 to 3 falls in the past 2 months. One of them, we have no idea why. A couple of them were related to icy conditions. With fatigue, there's been some medication changes to try to help with this. Gets, a good night's sleep in terms of the number of hours, but does snore, has lots of daytime fatigue, will fall asleep in the armchair, gets up for work around 6, but really struggles to get up in the morning, and has been more short of breath when he's exerting himself. Some right knee pain, it might swell at times. Coughing during meals. It's not new, but it's become more noticeable, and they do notice that he eats very quickly. Other things, he's had no concerns with the recent dental and podiatry visits. He has not had any optometry assessment recently and has not had his hearing checked. And then vital signs, so blood pressure about 130/89, heart rate in the 60s, stable weight, BMI of 33. And the next slide just looks at what the HELP framework is. This is how we approach things to identify potential contributing factors. So several different things there. that are listed that could fit under the health category, but also loss in the environment and supports, including like that inflexible work schedule, sleep hygiene, inadequate support potentially for increasing needs. There's a few factors here that we don't know quite yet and needed to explore further. Potentially some lived experience issues with grief, maybe there's prior trauma. Then we know that psychiatric, there's a mood disorder, but is there also anxiety or dementia? Lots of things potentially to explore here. The next slide just shows I did a thorough physical exam. It was mostly normal. There was a little bit of abnormal findings with that right knee. Sensation was difficult to assess. There was the right ear was blocked with earwax, and so potentially hearing was contributing to how he would process information or how quickly he would respond. Maybe the memory issues might be related to just not hearing properly. So I ordered a number of different investigations looking at each of these issues. So some blood work, a microarray to see if there's a specific diagnosis associated with that intellectual disability that might give us other clues into the health and kind of course of that diagnosis, things to expect and watch for. With recurrent falls, I wanted to look at bone density, to look at the fracture risk, also an echocardiogram just to look at the baseline function and any structural abnormalities associated with the heart, thinking about the falls, but also the shortness of breath, making sure that the hearing and eye or hearing and vision have been up to date, spirometry to check breathing, getting an x-ray of the knee and trying kind of a trial for schedule to see the and see if it helps, maybe physio, try to swallowing assessment, trial of treatment for reflux, because that's very, very common among people with IDD. We wanted to do a screening for dementia that is tailored to people with IDD, because traditional cognitive testing is usually not very helpful for this population. Wanted to flush that right ear, make sure that hearing was optimized, and then get it checked with audiology. And then advocating for more flexible work hours because he was starting quite early, had a long day, and we needed to make sure he had the support in place so that he could maybe start earlier, sleep in longer, and make sure that his sleep is optimized and he's not rushed to get to work in the morning or having those long days as he's aging and maybe just needs more time to rest in between. We were making sure that he had a sleep study and making sure he's following up with neurology and just continuing to monitor, thinking that if we were looking at all these other things, maybe the seizure frequency would also improve. The next slide just shows kind of some of the outcomes of those investigations and interventions. So a lot of them were normal. The spirometry was inconclusive, but incidentally, we found that the baseline oxygen was quite low, especially with exertion, and he ended up qualifying for home oxygen. We tried an inhaler just because we couldn't rule out asthma. We did diagnose osteoarthritis, and then physiotherapy seemed to improve some of those symptoms. He did have some improvement with trying the acid blocker for reflux, and recommendations provided with the swallowing assessment also helped. He was diagnosed and treated for sleep apnea, so there's a little bit less daytime fatigue. There was an improvement slightly in mood, seizure frequency slightly reduced, but memory concerns persisted. So a lot of interventions here, but still not quite where we wanted to see things. We were waiting for a long time for the microarray and barium swallow though. And then I'll pass it over to Priya and to try to be a little more concise than what we were planning here, just to talk about kind of what happened next.
Sounds good. Yeah. So with these ongoing issues with the fatigue, the memory, and the increased seizures, one of the things that we wondered about was could some of the fatigue be due to increased silent seizures that we weren't completely aware of? So the approach was to try to actually increase his anti-seizure medications, even though there was a possibility that he was having side effects, and maybe be able to start a new medication and get rid of another medication that might have been more sedating. So that was the initial plan. So we did add another anti-seizure medication, and it was titrated as it should have been, but shortly after it was increased, he really declined quite rapidly. He became even more lethargic. He started to have difficulties with doing his own ADLs. His oxygen saturations deteriorated, and ultimately we did reduce that medication back to before he developed those symptoms, but has a very long half-life, and I think he was still probably experiencing some of those side effects. And then on top of that, with these desaturations, he did end up being admitted to hospital. The next slide. And so he, in hospital, he did end up in the intensive care unit. And the reason for that was this combination of decreased level of consciousness, probably due to sedating effects with the polypharmacy. He also developed aspiration pneumonia. And then while he was there, he was investigated quite thoroughly for contributing factors. He was found to be in heart failure with a decreased ejection fraction, which was different than his previous echo that was done a year ago, which was normal. He also was noted to have elevated ammonia levels, which was thought to be due to the valproic acid that he was on. So that prompted some other changes, kind of unexpected, to his anti-epileptic medication regimen. He ended up having a pulmonary embolism, which was probably provoked by his decreased mobility. And then because of the combination of the decreased level of alertness, he ended up having a PEG tube inserted for nutrition and to try to decrease the risk of recurrent aspiration. And so he did, with all these interventions, the main thing that was done was supporting him with antibiotics, oxygen, physiotherapy, and a lot of medication changes. With his anti-seizure medications, kind of got flipped on their head, but it all ended up being a good thing. So over the course of his stay in hospital, his oxygen needs improved. He was back to only needing the oxygen at night or with exertion. His mobility was getting better and better, closer and closer to his baseline, maybe not quite even at the time of discharge, but at least he was getting there. And like I said, those anti-epileptics were changed, and in fact, he had quite a good run with no seizures, 3 weeks, his last 3 weeks in hospital. He was able to eat orally, and the PEG tube, the plan at the time was for it to be removed. GCS was 15 out of 15. He was seen by cardiology. They added some medications because of the heart failure and plan to follow up with him as an outpatient, and I will continue to follow.
Perfect. So just looking at some of the unique aspects of the case, I think maybe we were all going to speak to this, but I'm just going to quickly go over it so that we can kind of get through the rest of the slides. But because the team was able to identify the changes from baseline, I was able to get involved early, do a thorough assessment, identify what that new baseline was, find some new diagnoses that we could then address, and that informed the acute changes in hospital a year later. For example, we were able to say, this is not a long-standing heart failure that was undiagnosed. We know that this was normal 1 year ago, and so that kind of changes the approach to management rather than assuming it's an incidental finding. The dietitian perspective, so we were able to kind of address low sodium, the blood pressure. There'd be lots of risks of treating blood pressure in this case, and we really want to reduce polypharmacy. The feeding tube, I think it was not removed at the time of discharge, and so there was some education and planning that went into that. With the neurology side of things, so because Dr. Figurado was able to follow in hospital, that was, I think, extremely helpful because she was so familiar with the baseline and what had led to the hospitalization, understanding that community context and what's available and the approach for supporting him at home. And then just that working relationship with COR made that so much more successful. With the psychiatry approach, that team-based care and holistic approach, understanding that there are non-psychiatric factors associated with all of this and looking at the big picture. And then the core supports and nursing. So he was supported by familiar supports in the ER and in the hospital. They really help to facilitate communication, advocate, and help with the discharge planning. And then going over some of the facilitators. So within the health environment and system, these are the things that we identify as really making our approach effective. So there's flexibility of physician compensation models, but also a lot of the different approaches make it more feasible. If there is like a more traditional fee-for-service payment model, it does still make it more effective and more just possible, I guess, to provide high quality care and make it more efficient. Interdisciplinary case conference format really helps high quality referrals and documentation, strong collaboration between the physicians and the agency health team. And then the next slide, the clinical practice and community agency. So we have an accessible clinical environment. It's also very familiar, welcoming, adaptable. Sometimes we do home assessments. It's a beautiful space at the COR headquarters. We've seen pictures throughout. It's colorful. There's plants. Sometimes the psychiatrist brings his dogs. And so it's very different from like a traditional healthcare setting. There are consistent and familiar clinical administrative staff that are really helpful, as well as agency support staff. The low staff turnover is extremely helpful. More enhanced communication support and documentation and monitoring. The culture that we spoke about and that gentle teaching philosophy, the trauma-informed approach, and then flexibility and accommodations with scheduling, like having those dedicated blocks of time for COR with the neurologist. The next slide just shows provider facilitators. So that embedded nursing and dietitian team is huge. The specialized training and expertise, or even just the interest or the experience, or just being more open-minded and being humble, knowing that it's okay when you don't know something, that it's a big shift in attitude compared to what we sometimes experience in healthcare. The culture of continuous learning, that's for the healthcare team, but also for the supports at the agency. Strong interprofessional relationships and that prepared synthesized information makes getting any healthcare professional involved, it makes it so much more efficient and effective. The next slide just references the barriers I mentioned before. So really hard to significantly influence the overarching healthcare environment and system, but at least at the clinical practice and provider levels, I think we're doing a lot to address all of those. And then the next slide, we're going to hear from Jason one more time. So he'll be explaining kind of how he thinks healthcare should be delivered and what it's like receiving care from the COR health team.
I think that doctors should care about everybody, about either even know that you have a disability or you don't have a disability. You do need health. You need to have a doctor's appointment because everybody has to. Needs that support. And I don't think people should be scared to go into your guys' office if there was somebody that, let's say, needs some needles that need to be a blood work or something that needs to be checked, or maybe somebody needs their tonsils to be checked. Because I know people from here. And I can have fun or communicate. Because I'm not shy about it. I'm not embarrassed about it. And I just think it feels good to talk to somebody. And somebody that I know now. And that I'm not really scared about the person. It just feels good.
Perfect. The last slide is about future directions. So I won't read it all out, but there, of course, are some ongoing barriers that exist. And then if you click one more time, there's opportunities for improvement and future wishes. We would love to be able to expand access to more professionals, and then also just expand a similar care model to meet the health needs of people with IDD across the province, no matter what agency they're supported by, which would mean more partnership and collaboration between different sectors. But I think, it's all we have time for. I hoped that we would have time for questions. I'm happy to stay on in case there are any questions, and it will be, I guess, in the recording. But I think that was everything. And if anyone else has any last few words from the speakers, please do share if we missed anything that was important.
Thank you so much to all of our speakers today. You finished right on time, so I don't see any questions in the chat. So I do really want to thank each of you for really highlighting how care can be transformed with these interdisciplinary embedded health and home and social supports. It really was an inspiring view on how it can be improved for inclusive care. So the recording will become available. We'll send out the link once that becomes available. I do want to just quickly share evaluation link for today's webinar in the chat. We'll also follow up with the evaluation link afterwards. But again, on behalf of all the attendees today, thank you to all of the speakers for sharing your expertise and the work that you do. I wish everyone a wonderful day. Thank you so much.